Now, I have the real pleasure and honor of introducing Dr. Eric Olson. Dr. Olson received his medical degree from the University of Minnesota. He completed his internship and residency in internal medicine at UCSF, then his fellowship in pulmonary and critical care medicine and sleep medicine at Mayo Clinic, Rochester. He has been a staff physician at Mayo Clinic since completing his training in 1996, and he loves snow there. He's currently a professor of medicine at Mayo Clinic and is currently a chair at the Division of Pulmonary and Critical Care Medicine. He was also a former co-director for the Mayo Clinic Center for Sleep Medicine. Dr. Olson has contributed significantly in education and has received many awards, especially as top educator and best teachers many a times. He has also lectured in multiple courses in sleep disorders nationally and has authored more than 100 publications. His research is primarily focused in narcolepsy, different positive area pressure modalities for sleep disordered breathing, and cardiovascular disease mechanisms in sleep disordered breathing. Dr. Olson has also held leadership position in many national societies and is also the president-elect of the American Academy of Sleep Medicine currently. Thank you so much for being with us, Dr. Olson. And without any further delay, I would like to hand it over to you to share your expertise on one of the most difficult and challenging topic, DOT and sleep. Thank you again.
Oh, thank you for the very kind introduction. I really appreciate the opportunity to be here today. So without further ado, let's jump into this topic of DOT and sleep. So here's the disclosure slide with the CME code. I have no disclosures to make that are relevant to the talk. And on the first handful of slides, the code will be in the upper left-hand corner if it goes by too quickly now. All right. So really, the learning objectives today are to explore the regulatory requirements and guidelines that are available for commercial motor vehicle drivers or pilots with suspected or known sleep apnea. And then, as time allows, we'll review other federal regulatory policies regarding sleep disorders beyond obstructive sleep apnea. So this slide is really important to kind of temper the rest of what you're going to hear. So first of all, I'm not a DOT medical examiner or an aviation medical examiner. I'm a clinician at heart, and Mayo has a very active aerospace and medicine department. And I learned early on when I was here that we saw a lot of pilots and issues with sleep apnea came up, and I'm just sort of self-educated along the way. It's also going to be abundantly clear as we talk that there are many gray areas here, both from a policy and a clinical aspect. And I am certain there are going to be people in the audience whose experience may be different from some of the things I'm about to share. And that's fine. That's kind of to be expected in this realm. And I'd be happy to hear kind of contrary views or experiences as the talk goes on. I also would emphasize that as we get into some of those gray areas, you can never go wrong by simply adhering to the standards of practice and exercising your best clinical judgment, because as we'll see at the end of the day, that's really ultimately what you have to fall back on. And then kind of the last general point I would make is that it's very important to work in this area and cultivate a culture of partnership with the medical examiner that has referred the patient, partnership with the patient, partnership perhaps with the patient's employer, and then also holding your partnership to the public safety. And creating that trust and paying attention to those various needs is really critical. All right, so we're going to start by looking at kind of defining what a commercial motor vehicle driver is. And it's someone that's driving a business vehicle that's designed to operate on roads. This separates them from farmers who operate heavy equipment or heavy equipment operators. And that vehicle has to weigh at least 10,000 pounds or carry passengers. And that's at least 8 passengers if you're being paid to operate that vehicle, or at least 15 passengers, regardless of whether you're getting paid to operate that vehicle, or what you're transporting is a hazardous material. Now, the picture of this driver is pretty much typifies what a commercial driver is like in the US. They're not over 90% male, they're middle-aged, and the majority are Caucasian. Now, there are about 8 million commercial drivers in the US, and in 2020, which is the last year we have statistics, they drove collectively about 300 billion, that's with a B, miles. Now, the rules of engagement with commercial motor vehicle operators are dictated or established by the Department of Transportation, and in particular, one of the branches of the Department of Transportation called the Federal Motor Carrier Safety Administration. So when we're talking about commercial drivers and the DOT, we're really talking about the FMCSA. That was established, it's a relatively new government organization, 1999 by Bill Clinton. And the current secretary is shown there on the slide, and she operates under the direction of Secretary Buttigieg. Now, the FMCSA's main goal is to reduce fatalities or crashes as a result of the operation of trucks and buses. And they do that in 3 main ways: hours of service regulations, vehicle standards, and what we're going to concentrate on today, which is proper driver qualifications. Now, to be a commercial driver in the US, these are the things that you have to have. You have to be at least 21 years of older if you're involved in interstate commerce. It may be less if you're an intrastate. You have to be proficient in English. You have to have a valid commercial driver's license, which is based on passing a road test with the vehicle. And you have to hold a valid medical card or medical certificate, and that's what's issued in what's called the DOT exam. Now, the DOT exam, effective 2014, so 10 years ago, the DOT established that to conduct a DOT exam, the examiner must be registered by the DOT. And to be registered, you have to have completed and passed mandatory education, and then you have to have passed an exam based on that education. And that exam is a 10-year certificate. Now, there are about 50,000 DOT examiners in the US, and you can locate them online. There's a website to look at this National Registry of Certified Medical Examiners. Now, to be a medical examiner, you have to be a credentialed provider, which means MD, DO, and APP, or in all but 6 states, a doctor of chiropractic can also be a registered medical examiner. Now, the medical examiner and the sleep specialist can intersect or merge in a number of ways, but these are kind of the most common questions that usually come up. Should a driver be pulled from service while you're working them up for sleep apnea? Must the obstructive sleep apnea that you find be treated? What is adequate CPAP compliance? And when is a driver safe to return to work? So we're going to look at some of these things in the slides ahead. All right, just a couple statistics before I'm going to ask you a question. Crashes involving a truck or bus and an individual occurs about every 16 minutes. So during the course of today's talk, 3 people will have been injured or killed by a crash involving a truck or bus. And we know that sleepiness is relevant to about 1/3 of crashes. And we know that crash risk is increased if a driver has obstructive sleep apnea. And we know that obstructive sleep apnea is overrepresented in the population of commercial motor vehicle drivers. There have been a series of publications kind of positively showing that in the private setting where a trucking operation establishes a comprehensive detection, treatment, and management of obstructive sleep apnea program, you can clearly show reductions in crashes, hospitalizations, or healthcare expenditures in the drivers with such programs. All right, I'm going to ask a question here that will kind of set us up for some of the subsequent topics. So you are seeing a 55-year-old in sleep clinic with strongly suspected OSA. As you discuss your impressions and plans, he reluctantly divulges he's a long-distance trucker and asks what impact your workup will have on his job. Which of the following correctly describes existing federal law for commercial drivers and obstructive sleep apnea? A, PSG is mandated for diagnosis. HSAT is not allowed. B, the driver must report that he has had a sleep test on all subsequent DOT exams. C, therapy is required even for mild OSA before driving can resume. Or D, oral appliance therapy is not permissible since adherence cannot be tracked. So I'll have you think about that and maybe mentally put your chips down what you think is the right answer. And I'm going to share with you that D, or B rather, the driver must report he's had a sleep test is it would accord with current federal law. So let's go into this a little bit farther. So at the end of the day, there is in effect only really one law when it comes to drivers and sleep apnea and driver eligibility. And that's what's described in the Code of Federal Regulations, or the CFR, which is the codification of all federal rules. And the chapter and subchapter and subpart that describes commercial motor vehicle drivers is under what's called Title 49. And obstructive sleep apnea is not specifically mentioned under Title 49. It's subsumed under the respiratory dysfunction rule. And that rule simply is that a person can be physically qualified to drive a commercial motor vehicle if that person has no established medical history or clinical diagnosis of a respiratory dysfunction likely to interfere with the ability to control and drive a commercial motor vehicle safely. All right, this is it. This is the extent of the rules, if you will. Now, FMCSA acknowledges obstructive sleep apnea, and as we'll see, has issued some guidance, but they have no official statutes for OSA screening, diagnosis, and treatment. And that's what makes this area really difficult to operate in, but we'll explore this further. All right. There are a variety of sources where you can go for guidance in how you can extrapolate that very general respiratory dysfunction rule to the specifics of obstructive sleep apnea. Now, there are guidances issued by ACCP, ATS, AASM, occupational medicine organizations. So there are many out there. On this slide, I've highlighted 4 of them, and I'm going to highlight one in particular, which is the FMCSA's Medical Review Board Bulletin of 2016. So FMCSA on several occasions has brought together groups of sleep experts to try to come up with guidelines upon which then rules could be made. They could issue rules. And the last time they tried to do this was in 2016. The 2016 Medical Expert Panel Report is what I'm going to highlight because I think it's the closest thing that we can get to what the FMCSA is actually thinking and therefore could act in accordance with that. Now, I mentioned earlier that medical examiners have to go through training. And the training that a medical examiner receives with respect to obstructive sleep apnea is based by and large on this review board report of 2016. So for that reason, also, I think it's probably the best source to look at. I will point out that the AASM did issue a guideline in 2017. If you're so inclined, you can look to that for specifics. But I have to emphasize, all of these are just guidelines. They are not federal law, and therefore you are not mandated to subvert your clinical judgment to these guidelines. I would point out one other thing. You may be thinking, why doesn't FMCSA just release something and take that report from 2016? And that's because of the following. If you look at that box at the bottom of this slide, the trucking lobby in 2013 got Congress to pass a law that said all rulemaking for obstructive sleep apnea in commercial motor vehicle drivers has to be done by Congress. It is taken away from the FMCSA. So the FMCSA can make recommendations, but Congress has to eventually pass regulations. So those of us craving more kind of codified guidance, like what exactly do we need to do beyond that Title 49 respiratory dysfunction, are going to have to wait for Congress, and you know how that may go. All right, so when a driver goes in for their DOT exam, they have to fill out a form. It's form 5875. And on that form, they have to provide the examiner with information regarding the medical history. And questions 25 and 26 on the report, which are highlighted here, ask about obstructive sleep apnea. And if you look at the bottom, when the driver signs the form, it is indicated that it would be a federal violation if they do not disclose that they have ever had a sleep study. So we'll go back to the question in a moment, but this is the answer. The only other rule really here that applies is that a driver has to say, if they've had a sleep study, that has to be divulged on all subsequent DOT exams. And we all know why drivers may be hesitant to do this, but technically they are held to that standard. All right, what the FMCSA medical expert panel in 2016 said about patients with suspected obstructive sleep apnea was as follows. They said, number one, all medical examiners must screen for sleep apnea at every medical exam visit. They also emphasized that objective measures are more important than subjective symptoms in determining assessment for OSA risk. And that's because drivers are notorious for underreporting their symptoms. So in the next bullet point, they came down on these standards as when a driver should be referred by a medical examiner for a sleep evaluation. So anyone with a BMI of 40 or greater, or between 33 and 39, and 3 or more of the following things listed there. Now, these things were purely compromised based. There's no scientific basis for why these BMIs are better than another. But I'm sharing them with you because these are what medical examiners have been taught and are often looking for. And you've probably all seen drivers that come frustrated because they may not have symptoms, but they said, well, the medical examiner said because of my BMI, I have to come. And that's the origin of that. All right. They also said that if you had a previously negative sleep study, which was defined by an AHI of under 20 events per hour, we'll come back to that number. You only needed to be restudied if you gained 10% or more of your weight or a change in symptoms or risk factors. Now, if you don't like these recommendations, that's fine. Again, you can always go back to your clinical judgment, but this is what's guided, not in law, but guided by FMCSA. For drivers with suspected sleep apnea, they recommend that there should be immediate disqualification if that patient admits to fatigue or sleepiness during their main wake period, and that's usually not what will be acknowledged. Number two, if they've been involved in a sleep-related motor vehicle crash or accident or near crash, or they appear to be at extremely high risk for severe OSA, like obesity hypoventilation. FMCSA counsels that in all others that don't meet those three standards, that it's okay for the driver to remain in operation under a 90-day conditional certification, right? The FMCSA has said in that 2016 report that a PSG is referred, although an HSAT is an appropriate option. But if the HSAT is inadequate, PSG must be performed, that a negative HSAT is not an endpoint. For patients with known sleep apnea, the question always comes up is how much is enough sleep apnea to be treated? What the FMCSA came down on the basis of their medical expert panel in 2016 was that anyone with an AHI of 20 or greater should be treated. If you had an AHI of under 20, treatment could be passed upon if the patient did not have excessive daytime sleepiness. So this is obviously problematic because I've said earlier that drivers are notorious for underestimating their drowsiness, but you have to be able to draw a line somewhere. Now, this doesn't mean you have to follow this. If you have other good reasons that even with that mild OSA, you seek treatment, fine. But for those kind of seeking guidance and having that driver that may be resistant to treatment, this is what the expert panel suggested would be the line in the sand. 20 or greater, or between 5 and 20 if the patient acknowledges or has a history of excessive sleepiness. Okay, so treatment not mandatory for mild OSA without sleepiness. PAP is the preferred option, but the expert panel did come down on oral appliance is an option if PAP is intolerable, okay? They also stated, and this is actually practiced but not in law, that if a driver has been diagnosed with sleep apnea, the interval for their medical exams should be every year as opposed to every 2 years. All right, they said that a driver may return to work in 1 week, okay, at least 1 week on PAP, if they're adherent, and they came down on the CMS qualification of 4 hours a night on 70% of nights. So 5 out of their first 7 nights, they used the CPAP, and they no longer were reporting excessive daytime sleepiness, all right? And then again, they recommended annual recertifications, not every 2 years. With regard to oral appliance, again, they also recommended 1-year recertifications instead of 2 years. And the oral appliance was a viable long-term option if follow-up sleep testing showed resolution of moderate to severe OSA, meaning the AHI was back below 20 events per hour. And they left some recommendations for surgically treated patients, and I won't go through each one of these, but I would point out that if it's bariatric surgery, oral pharyngeal soft tissue surgery, or orthognathic surgery, there were just slight variations. So for the bariatric surgery, they actually said the driver needed to stay on the adjunctive therapy, CPAP or oral appliance, for 6 months until the driver comes back and has a repeat sleep apnea test to see where things stand after weight loss has occurred. Whereas for the orthognathic or soft tissue surgery, it was basically at 1 month, the driver needed to maintain therapy with CPAP or an oral appliance until they were retested and showed the AHI was back below 20 events per hour. Now, again, I want to emphasize, if this affronts your clinical sense or you don't agree, these are not written in law. This is just what the medical expert panel convened by FMCSA, and what FMCSA was planning to propose is where they came down, and therefore it may be one set of standards to use as you make decisions with your commercial drivers. So if we go back to my question about the driver you're going to work up, I don't think was right because PSG is not mandated. There's no mandate in federal law. You can choose what type of testing, the modality you want to use. And that may be dictated by the insurance rather than your clinical judgment. I thought B was right. Again, when they sign that form, 5873, they have to attest if they've had prior sleep testing. Therapy is not required necessarily for mild sleep apnea, which DOT defines in their medical expert panel as an AHI less than 20 if the patient does not have a history of drowsy driving or acknowledges that. And then an oral appliance is technically a permissible option. I just want to touch on the FMCSA and a couple other sleep issues. The FMCSA does not specifically comment on central sleep apnea. However, one thing that you could be aware of is that they are on record as stating that an LVEF, an ejection fraction of less than or equal to 40%, is a disqualifying diagnosis. So if at least you're looking at central sleep apnea of the Cheyne-Stokes variety, and therefore likely due to an underlying left ventricular systolic function issue, you could perhaps extrapolate from the LVEF decision, kind of where things stand with CSA. But FMCSA does not have any official guidance on central sleep apnea. And that would also include treatment emergent central sleep apnea. There's also no official guidance on obesity hypoventilation syndrome, all right? However, if you look at memos issued by the FMCSA where clinicians have made inquiries and have been seeking guidance on gray areas, the FMCSA is on record as saying, in most cases, the use of oxygen therapy while driving is disqualifying. So I guess I would conclude that if you have an obesity hypoventilation patient who whose condition is marked by awake hypoxemia, not necessarily the need for oxygen just at night, but around the clock, that theoretically would be disqualifying, independent of what's happening with the PAP therapy. What about the FMCSA and central disorders of hypersomnolence? Now here, the FMCSA has been quite clear. And the FMCSA conducted, again, another medical expert panel that issued a report in 2009 that has not been updated since then, where they looked at narcolepsy types 1 and 2. And they firmly concluded that narcolepsy was associated with increased crash risk, and that existing pharmacotherapies do not return most narcoleptics to normal alertness. And therefore, they concluded that narcolepsy or idiopathic hypersomnia are disqualifying conditions. Now, multiple exemptions have been requested for this. And it's interesting, whenever an exemption is formally applied for, it becomes part of the Federal Register. So you can see kind of what has happened and what's been decided. The last one I could find, I believe, was 2021. A driver from Illinois had applied for an exemption, and it was denied. And that has been the consistent response to the FMCSA. So narcolepsy and idiopathic hypersomnia would technically be disqualifying conditions regardless of treatment. Now here's another gray area, because you may be thinking, well, what about the adequately treated obstructive sleep apnea patient who continues to be sleepy, and therefore there is FDA approval to use modafinil? And interestingly, even though FMCSA has concluded and held to the disqualifying nature of narcolepsy and idiopathic hypersomnia, the combination of treatment for sleep apnea with modafinil is allowed. And so, like many areas here, if you look at the different, society guidelines or FMCSA memos and guidance issued, there are always discrepancies and inconsistencies, and this is one of them. FMCSA says that there are exceptions for Schedule 2 through 5 drugs if it's the feeling of the medical team that that substance will not adversely affect the driver's ability to drive safely, and that treatment has been shown to be adequate, effective, safe, and stable. Now, all that sounds great, but that is really hard to do, because as we'll see on the next slide, we don't have great tests to show that treatments that may impact alertness or ability to operate in a safety-sensitive situation are truly indeed safe. And you may be thinking about the MWT, and like I said, we're going to address that on the next slide. So ultimately, if you have a driver on one of these controlled substances, the medical examiner is going to look to us, to help make a decision on a case-by-case basis. But remember, the medical examiner, they can't diagnose and they can't treat, but it's the medical examiner's ultimate call about whether the patient is qualified or not to drive. So you can offer guidance, but the final decision rests with the medical examiner. Now, you may be thinking about the MWT and where does that come in, the maintenance of wakefulness test. And this is problematic because the predictive ability of the MWT for assessing accident risk has not been firmly established. I'm going to show you one of a handful of studies that's looked at this. It's on the next slide, but this is clearly not something that's been firmly established. And part of the problem also with the MWT is there's a huge range for normative values. If you look at that third bullet point, the mean initial sleep latency on an MWT for normals is 30 minutes, with 2 standard deviations extending down to 19 minutes. And so that's really hard to operate and operationalize an MWT score. The available literature of what little there is, I think most people would have a consensus that there does appear to be an increased risk for driving, at least in a simulation setting, if the mean initial sleep latency is under 20 minutes, all right? So if you're thinking about, is the treatment of CPAP and modafinil effective, and I need to show that, we're going to be looking for an ISL that's longer than that, all right? And I think at the end of the day, you have to combine your clinical gestalt with any objective data you bring to it, adherence to therapy with or without an MWT, to make your own sense of the driver's fitness. Now, this is one study. It's only a handful, but I picked this one out because it's one of the very few where they're comparing MWT scores to driving in the real world setting, all right, so on the road. So what you're seeing here are two groups of patients. One group was patients with severe obstructive sleep apnea, and then a control group that did not have obstructive sleep apnea. The group that had obstructive sleep apnea was chunked into three groups. Those whose MWT initial sleep latency was 19 minutes or less, those that had a 20 to 33 minute mean initial sleep latency, and those that were able to stay awake on average 34 minutes up to 40 minutes, all right? They took those groups then, and they took all of them out onto the road, and they had them drive on the highway under observation. And what they were looking at in a 90-minute driving test on the highway was how many inappropriate lane crossings occurred. Now, you could argue with that as an endpoint, but that's what they used. And so the higher on the vertical scale, the more inappropriate lane crossings that group had. And you can see it's clear that the groups that had the mean initial sleep latencies of the very sleepy or sleepy, so up to 33 minutes, those groups had more inappropriate lane crossings. Okay, it wasn't a lot, but there were more than those that had a mean initial sleep latency of 34 minutes or longer, had OSA, or the controls. All right, and the same results have basically been showed in narcolepsy as well. So there seems to be some validity there. Now, last slide for this part is that the commercial motor vehicle driver bears responsibility themselves, and they really need to be held to the fact that driving a commercial motor vehicle knowingly with any condition that would be disqualifying or interfere with safe operation, even if they're holding a current medical certificate, is prohibited, all right? And they are responsible for obtaining recertification from a properly qualified medical examiner. All right, I'm going to go on to the aviation industry in the time we have left, and then I'm sure there are going to be questions, and we'll go from there. All right, the aviation industry, just a few statistics to share here. As you look up into the sky as we speak, there are probably about 5,000 aircraft in the U.S. airspace right now, and there are about 750,000 U.S. pilots. And about 5,000 of the FAA certified pilots do have obstructive sleep apnea and are flying with what's called a special issuance. That is, their condition is acknowledged, it's treated, and they're approved to fly. Now, again, the responsibility lies under Secretary Buttigieg, but in particular with his branch of what's called the FAA. And the current secretary is listed there, current director rather. And the FAA is the one that makes the rules here. Now, the rubber meets the road with what's called the Aviation Medical Examiner, the AME. And the AME is a physician or DO that's received specialized training in the medical and physiologic aspects of flight. As of now, an advanced practice provider cannot be an aviation medical examiner. The aviation medical examiner is trained by the FAA, and they are appointed to that status by the FAA. And they are the ones charged with conducting these exams on all facets of the airline industry or flight industry. So pilots, air traffic controllers, and aviation safety inspectors. Now, the AME answers to one of 9 regional flight surgeons. All right, so the country is chunked up into 9 sections, and the regional flight surgeons all answer to the federal air surgeon. So the federal air surgeon has the final say on decisions. Now, the aviation medical examiner cannot independently certify a pilot to fly at their first examination. That first decision comes from the regional flight surgeon or the federal air surgeon. The AME is able to recertify pilots as long as they continue to meet standards. So the AME in some respect can operate independently. In other respects, they have to answer to a higher hierarchy. Now, the AMEs operate under the Guide for Aviation Medical Examiners Handbook, which I've given you the website here. If you want to go and look up exactly what the rules are, what the FAA has established for conditions that they've commented on, this is where you will find the information. And I'm going to subsequently summarize what is currently listed there for obstructive sleep apnea. But the Guide for Aviation Medical Examiners is your source. So to set this part of the talk up, I just want to ask a question here. So a pilot is referred to sleep clinic for suspected sleep apnea. She has restless leg syndrome and recently started ropinirole. She occasionally uses zolpidem to resynchronize after international flights. She denies excessive daytime sleepiness or Epworth 5, and her PSG reveals moderate obstructive sleep apnea, AHI 19 events per hour. Which of the following statements is correct according to FAA? Number one, she cannot fly until a minimum of 30 days of CPAP adherence is documented. B, if CPAP is prescribed, the adherence target is the same one used by CMS. C, her use of ropinirole is disqualifying for flying. D, her use of PRN zolpidem is disqualifying for flying. So I have you think about that for a second. And the answer may surprise some, which is ropinirole here is the bad actor. And we'll get to the ropinirole at the end. Okay, so in 2015, the FAA issued updated guidance about sleep apnea to their medical examiners, and that's still what carries the law of the land. And as I'll show you on subsequent slides, at each medical exam that the AME conducts on a pilot, they have to categorize the airman or the pilot into one of 6 groups. So let's walk through that. So the first group would be a pilot who has known sleep apnea. It's already been acknowledged by the FAA, and the pilot has received what's called a special issuance, which means they have a disqualifying diagnosis, i.e. OSA, but it's been treated, and therefore a special issuance or acceptance has been issued. If that's the case, the AME, the examiner, can just reissue a certificate to fly as long as the following reports are submitted. And this is where you come in and I come in. For a pilot with known obstructive sleep apnea, the pilot has to sign a compliance with treatment sheet, which is listed here on the right side of the slide. And if they're on PAP, the pilot has to submit to FAA a cumulative annual PAP adherence report. Okay, so for 1 year, and the target goal is actually 6 or more hours a night for at least 75% or more of sleep period. So it's not the CMS guideline of 4 and 70%. And ideally, the download should show an AHI of less than 5 events per hour. If the pilot's on oral appliance or positional device, they need to just document that they have no conditions known to be comorbid with OSA, which is a tough ask because if they have hypertension, for instance, that would be disqualifying. All right. So as the sleep provider in this, you need to partner with the pilot to provide that annual PAP report and attest to that adherence standard. Okay. If the pilot has been diagnosed with sleep apnea since their last exam, so FAA does not know that since the last time they were certified, they were diagnosed with sleep apnea, the pilot can keep flying for 90 days, but once they've gone in and seen the medical examiner, they have to submit within those 90 days all their OSA records, that signed treatment compliance sheet that I shared with you on the previous slide, and they need a status report from us. So we need to say they're adherent and therapy is effective. Okay, so we will need to partner there. If the pilot does not have OSA or has not been diagnosed with OSA, the AME has to assess risk factors, and the FAA said use these two tables to look at risk conditions or symptoms in response to the questions on the right to determine risk. And we all know these, so I'm not going to belabor them. So if after that risk assessment, the pilot is deemed to be at risk for sleep apnea, the FAA recommends a type 1 study, so an in-lab PSG or an in-home full PSG, which we don't do a lot of. The FAA will technically accept a home sleep apnea test where they say in communities where type 1 and type 2 testing is not easily available, okay? But that must be read by a sleep specialist. If the study shows sleep apnea, FAA on record says that in most cases, OSA defined by an AHI of 15 or greater will require therapy. Now, if in your clinical judgment, you would want to treat at a lower AHI, there's no stopping you. But if that pilot is saying, look, do I really need to be treated? And you're at a point of equipoise, that is one number that they have gone on record with, okay? Now, if the pilot is newly diagnosed, again, they cannot fly until they have submitted to the FAA the sleep study results, that compliance with treatment form that I showed you several slides back, and a status report from us addressing compliance and treatment tolerance and resolution of symptoms. Now, FAA has generally required at least 30 days of treatment, but they will consider a minimum of 2 weeks of treatment if the data verifies excellent compliance, effective treatment, and resolution of symptoms. So the pilot may not have to be out a full month before they can return to work. And again, that's just shown on this busy slide, and this would be high risk for OSA, and they're treated, and they have that 90-day grace period to get that information in. Okay, so what about beyond OSA? We're coming to the end here. With regard to central sleep apnea, narcolepsy, idiopathic hypersomnia, restless legs, all of those would require, if they're new diagnoses, a deferral. So the pilot cannot be cleared until the regional flight office or the central office have helped decide whether a special issuance can be determined, okay? Sleep aids are allowable if they're for limited use and only for circadian resynchronization, all right? Daily or nightly use of sleep aids is not allowed regardless of indication. And the FAA has gone on record that if you take one of those drugs listed on this slide, from diphenhydramine down to extended release zolpidem, there is a minimum wait time between drug ingestion and going on duty, all right? And I just would point out that top one, Benadryl, would be 60 hours per the FAA. Last but not least, the FAA has issued a do not issue medication list, all right? So these are drugs that if the pilot is using, they are automatically disqualifying. There are no exceptions, and they would be any Schedule 1 through 5 drug. And interestingly, on the list are dopamine agonists because of the potential risks for sleepiness, including ropinirole. Now, interestingly, carbidopa levodopa does make the cut, but gabapentin does not. Okay, so if we go back to our question, A, the FAA will theoretically look at a pilot returning to service if they've had a successful first 14 days on CPAP therapy. So it's not in law that they have to wait 30 days. Number two, FAA uses the more than 6 hours a night, 6 or more hours a night rather, for 75% of nights or greater to determine the threshold for PAP adherence. Ropinirole, interestingly, is disqualifying for flying, and D, PRN zolpidem is not disqualifying. Nightly zolpidem would be. So my take-home points, drivers and pilots should be disqualified. So immediately, if they're referred for OSA and they admit to fatigue or sleepiness, they've had a mishap because of that, or they appear to be at very high risk. A final medical examination determination rests with the medical examiner, not you. The DOT FMCSA does not have official guidance, okay, for OSA screening, diagnosis, and treatment. If you're looking for what they're thinking, refer to the 2016 advisory panel report. They recommend treating mild OSA if there is EDS, otherwise reserving treatment for an AHI of 20 or greater and at least 1 week of minimum PAP adherence. Narcolepsy and idiopathic hypersomnia are disqualifying. FAA has far more detailed guidelines, and I would highlight their target goals for adherence. That's really the number to remember. And with that, I'm going to stop, and I appreciate your attendance, and I'd be happy to take any questions.
Thank you so much, Dr. Olson, for this very educational and very detailed, excellent presentation on one of the really challenging topics that has scarce data. I had a quick question. We discussed earlier that, there's so much gray area in this topic. What about, for patients who have HST, but we can clearly see there's underreporting, based on heart rate variability, and then, underreporting of symptoms, which kind of contradicts their family's history. They do have, or, patients who have significant, hypoventilation, perhaps, like, based on just HST with total, desaturation, total time below 90%, more than 50% or so, but not significant sleep apnea. Any guidance for those kind of patients or anything?
Yeah, great question, and been there many times, as I'm sure many on the call have been. I guess simply what I would say is I think at the end of the day, you have to fall back on your clinical judgment. And, we can cite these rules or lack thereof and what guidance is out in print. But I think at the end of the day, you have to stay true to what you think is the right clinical call. And I just can't emphasize that enough. I mean, we all are aware of the fact that an HSAT may underrepresent obstructive sleep apnea severity, especially, if you don't have an estimate of total sleep time that goes along with the device you're using. And so if you feel like that sleep apnea is more severe than just that number, which we can so slavishly follow, but it can be so deceptive, you have to use your best clinical judgment and not hide behind the fact that, well, okay, it's, one of the guidance issued by FMCSA says if it's less than 20, I'm in the clear. You just have to use your best judgment.
Yeah, that's very challenging.
Always. Always. And the driver, you know, they're hesitant. There's a lot of fear in the driving community about what this means. And, sometimes trying to divorce that kind of professional concern with, the patient's overall well-being can be a difficult road to navigate. But I think what I always do at the end of the day, if it seems gray, is go with what I think I would do if the patient, if the driving was completely irrelevant to the clinical decision making.
Yeah, great. Thank you. A few questions here in the chat. The first question that I have is from Dr. Toshiba Kumar. Is the ICD code Z02.4, which is, I think, encounter for examination for driving licensor, relevant for us, or is it for the medical examiner?
Yeah, I've never used that code. I like that question, but I can't answer it in a way that I think you're going to find satisfying. I always code my encounters based on what the sleep diagnosis would be, not using that code. So I would say, unless someone in the audience who is smarter can correct me, that's, I would think, is a medical examiner code, not a sleep clinician code.
The next question I have is, this is just an awareness by Dr. Karen Johnson. If you want to learn more about transportation and daylight saving time and circadian effects, sign up for a webinar there's a link, and next Tuesday at 1 p.m. Eastern, guest speakers from Military, United Airlines, and Schneider Trucking are there. So if anybody is interested.
I'm honored Karen was on. Thank you for that comment, and hello. But yeah, that Schneider, that study I cited earlier with the clear reductions in hospitalization and like per member benefit expenditures with a comprehensive sleep apnea program. They've been a real leader in that area. Schneider's kind of based up here in the upper Midwest and have really been on the forefront of kind of proactively guiding their drivers to OSA assessment and treatment.
Thank you. And she also has another comment. One of the hardest scenario is when patients lose their job because they can't work and then doesn't have insurance to get it treated, so ends up in a vicious cycle. Yeah, that's so true.
I wish I had, yeah, a nice tight answer for that. I've been there with drivers. Yeah, that's definitely one of the tough spots. And most drivers are not part of large trucking corporations. Most drivers are independent. And so they often don't have the benefit of a generous package that will support seeking medical care and, having treatment. And so that's a huge, huge issue.
Yeah. Um, there's another question which says, what AHI definition is being used?
Yeah, um, the that's a good question, and I don't know if I know the answer to that because um, let me just think there for a minute. The 2008 panel, um, which had Dr. Seisler and Dr. Pack, the first one that really FMCSA convened in the contemporary era, um, used the 1999 ASM kind of statement on defining apneas and hypopneas. I don't know if I've looked at that 2016 to know for sure. So that's a really good question. So you got me on that one. I would have to go back and look.
Okay. And I have another question here from Laura Wu. Are there any guidelines for providers who see pilots or CMB license holders, but not in the context of the medical exam, who are aware of the relevant symptoms or treatments?
I'm not sure I fully understand the question, so I'm off the mark here. Bear with me. I guess what I would hope is that, any decision making is made within, that greater context of that information is going to have to be relayed to either the medical examiner or the flight examiner. And so, doing your best to ensure that that pilot or that driver meets the recommendations for adherence to therapy, for instance, and to be mindful in your note that you're documenting adherence and assessment of therapy effectiveness, I think would be kind of the main things. At the end of the day, I think you treat the patient as the patient. And so anything that you would bring to bear on a non-commercial driver or pilot, would be the same here. I have a feeling I didn't hit the mark of that question, but that was my initial reaction.
Yeah, I think that's what the question was. If you're just seeing the patient in the context of, the symptoms
Yeah.
and
I think you got to do your thing. And, at the end of the day, you want to get that patient to an effective level of therapy, and whatever that takes, that needs to be done. But, and I think, my experience has been that in communication with the medical examiner and then with the regional flight surgeon, that they are open to hearing from us if we can paint a compelling story to show that that pilot is progressing appropriately, even if that full 1 year adherence does not look exactly perfect. And so we can also, get a payoff for those efforts to improve adherence if it's landing that pilot in kind of the territory they need to be.
yeah. Thank you. And then the other question is from Daniel McNally. How much confidence would you have in the AHI reported as part of the download information?
Yeah, I think we could all have a different answer to that question, huh? And I think often we look at it from the clinical bias that we bring to that encounter and what the patient has told us. It's great when it's showing what we want, and I think we have to pay attention to it. But just like an MWT, For instance, it has to be taken within the greater clinical context. And I think if there doesn't seem to be something quite right between what you're hearing and what that number looks like, then I tend to go digging further. And so, for instance, if that AHI level is up, and let's say, the patient was diagnosed via HSAT, so we don't know via PSG if there was a treatment emergent central sleep apnea response, maybe we go looking for that. Or maybe we do an overnight oximetry on therapy to see if that download AHI translates into any desaturations that might add credence to its validity. So I think it just has to be looked at in the greater clinical context rather than in isolation. And again, just its absolute value.
Yeah. The next question is from Dr. Joyce Lee Ianodi. Branching off of Karen's question, another really tough population involves military folks, even high school students applying for prestigious military schools, exclusion from application enrollment because of their OSA or narcolepsy diagnosis, which seems discriminating. What are your thoughts?
Yeah, hi Joyce. Thanks for the question. So I have not personally been in that situation, but that's been described by colleagues. And if that OSA can be treated, that should not be permanently disqualifying, but it has to be addressed. And so I don't know if I have anything really wiser to say on that, in that if you can show that sleep apnea can be addressed, and it doesn't have to be by CPAP, so that may be even surgically addressed, that candidate may yet be able to go through, but it is a early barrier at that application sort of eligibility stage.
Thank you, Eric. If I can just expand just for a second. So,
Please.
Eric, West Point specifically, I had a student who is exceptional that was applying to West Point and has narcolepsy, did not have OSA. And it seemed like it just was not an exception that they would work around, even with letters, being well controlled on a monotherapy. And
Yeah,
I understand from a military standpoint, they have to, I think, serve after their college experience. And
yep.
so there's always concern if they're in the battlefield, can they actually,
Yeah.
persist in that with that condition? But I'm interested to hear if others have faced this. It just seemed really unfortunate because he was so bound on going to West Point. He would have been like the fourth generation West Pointer in his family.
Yeah, thanks, Joyce. I answered that from the question of OSA. No, that has been the case that I have personally experienced one that for a central disorder of hypersomnolence. So it does seem rigid.
Yeah. Thank you.
That's very unfortunate too. We have someone here, Afia James, who's raised her hand. If you want to ask the question on your own, you can unmute yourself.
Hi, thank you. So I just wanted to make a comment. First, I just want to say that I'm a faculty in the Occupational Environmental Medicine program at Yale, and I'm also the chief of employee occupational health at the VA. Thank you for this excellent presentation. I medically certify VA drivers, and many of them have OSA. And I always ask the employees, the patients, to get their OSA documents from their sleep medicine providers. And this presentation was great in that it kind of outlined what I'm looking for when I get that documentation back, because sometimes, the providers don't know exactly what is needed. And so I agree. What I need is just basically objective information, and I can make the decision whether or not to qualify that driver. So thanks for kind of outlining what's needed when a patient comes to their sleep medicine provider and wants to and as a driver or a pilot and needs to be certified.
I'm
Thanks.
so glad you made that comment. I was scared you were going to correct 10 errors based on your expertise. So
No, you did a great job.
thank you for your input there.
Yeah, thank you. All right. Thank you so much, Dr. Olson. This was an excellent, fantastic presentation. And thank you everyone for joining us. We'll see you next week.
Really appreciate the opportunity. Thanks.
Thank you. Bye-bye.